Morning, everyone. So, I've been discussing about different ways of treating our patients and preventing the blindness. That's what we have been discussing, and how to run this more efficiently and get this done. So, we briefly touched about the pyramidal model of healthcare that Dr. Professor Pityal has talked about. So, it's basically about health for all, and we have lots of need. What are the problems, the challenges which we face? The challenges are there is insufficient workforce, less infrastructure, and the more people who are not all at one place, they are distributed all throughout the country. So, how are we going to deal with it? So, not many people, if you look at any of the ophthalmologists or an optometrist which we have trained, how many of them are ready to go to a village and work? So, it's going to be a difficult task to get them to go and do it there. And other thing which we realized, how many of our patients are ready to come to a city or a major town to get their health checkup done? For that matter, how many of us are ready to go to a doctor when you don't have much problem? A regular primary health care is going to suffer. We are not bothered about our health. The same thing happens with our patients, and they don't want to leave their work and spend 1 2 days to go to a nearest town and get their checkups done. That's not happening. So we need to do something for it. That's where the pyramidal model comes in, like what Dr. Tityal was talking about. The majority of these, Professor Ravindran was talking about, can be tackled 90% of them at their own place where they are in. That's where the pyramidal model comes into picture. So the importance of the pyramidal model, again, the base of the pyramid has to be broad. If not, the pyramid is not going to be stable. So you need to make sure that the pyramidal base is large. So the pyramidal model which we developed is consists of the people from the community, where we take them and train them a little and give them technology and techniques for them to identify minimum basic problems. So we have vision guardians who are usually there for 5,000 people. They take care of 5,000 population. So they go there, they are in the village, they are in the same village. They'll just go there, do this minimum screening. If they need anything, they raise an alarm. Okay, fine, you need to go to the next level. So the next level usually is a vision center. Vision center is nothing but a smaller setup where you have one exam room, what you have in your clinic. So you have a minimum basic equipment. Maybe along with that, you add a little more of technology, like a few cameras for you to do a teleconsult from there, so that they don't need to come to get an opinion from a doctor to a city. So the technician who's there just got trained for 2 years. They are not an optometrist. You pick up from them the community, train them, and put them back there. They're going to be there. You're going to create a job for them. At the same time, you are creating a resource which is going to be there with their community forever. It's not that when I have time I come to you. No, you are there every time. When the patient has time, they can come and get your things done. That's the difference. So that's the vision center which we do. So this model you goes to the next level, where we have people, when you identify the 10% which we are talking about, when you have 10% problems which cannot be tackled using a teleconsult or a refractive error which you have dealt there at that time, you go to the next level. That's called a service center or a secondary center, which we talk about. This is usually for a 5 lakh population. So when these centers are used with an ophthalmologist there in that place, these are in the smaller towns or centers which are, I would say, second tier towns. So where you have a setup, you can do a surgeries, you can do most of the cataract surgeries there, uncomplicated, and most of the minimal procedures, like even the glaucoma, like we were talking about, glaucoma is a major problem. Most of the glaucoma can be tackled in these centers. They don't need to come to a tertiary center in the cities. So that's what happens at the secondary center or service center. Things which cannot be handled in this place are the ones which needs to go to the tertiary center, where you have major specialists sitting there, or a high-end techniques and technology which is sitting there, which is not required in those centers. So we call this as a group of vision guardians, vision center, secondary centers as a village vision complex. The whole thing is a complex. When all this work together, only then this will work again. It's not it's not enough for us to have each level are not working together. So the thing which we have in these centers is if once a patient is into the system, his record can be accessed from vision center to the tertiary center, whatever, wherever there, and then can go back to the vision center. There's still the record is maintained, and you can actually see, monitor the patient right from all throughout the network. That's what makes it unique. So that patient does not need to worry about I have to carry too many things. I go to a different center, I don't know what's happening. So that's the village vision complex to integrate. So this is the thing which happens. So this patient and the vision center in the remote rural village was picked up by a vision technician to have a retinoblastoma when they were screening it in the vision center. Sent back to the secondary center, realized that this needs to be done to the tertiary center. So instead of going there with the teleconsult, we send the patient directly to the tertiary center, get the treatment done, and then go back to the vision center. And whenever it's required, he'll come back. So that the patient need not travel too much. And if any time we go to a different town, you need to stay there. We are only talking about our cost. We are not talking about what the patient it costs to. We might do surgery free, but the patient also spending other than that. So that's something we need to be cognizant of that fact. So that's where the pyramidal model comes in, and the tertiary centers which will take care of any of the complex issues. So this is our network. If you look at the base, so all those green dots are all the vision centers. So each secondary center has a 10 vision centers around it, and each tertiary center is again connected. So the lines which are there, they're all connected to the next level. So that's the distribution. We still see there's lots of gaps around. We still need to work on it, and that's not going to happen only with us. We all together we can work together to make it possible. So it's not that one person can do this or one organization can do this. Like government is, it's not enough for only government to work on it. We all should be able to do this. Only then we will be able to do all this possible. So that's in short about pyramidal model, and we all can work together.